Ovarian cancer symptoms, treatment, prevention, survival. In this video, you will learn the nature and characteristics of ovarian cancer, ranging from formation to advanced stages. You also learn prevention methods to help you decrease the risk of having the cancer, as well as survival tips. But before we continue, kindly support us by subscribing to the channel and hit the bell icon for notifications of new uploads. Ovarian cancer is a cancer that forms in or on the ovary. It results in abnormal cells that have the ability to invade or spread to other parts of the body. When this process begins, there may be no or only vague symptoms. Symptoms become more noticeable as the cancer progresses. These symptoms may include bloating, pelvic pain, abdominal swelling, and loss of appetite, among others. Common areas to which the cancer may spread include the lining of the abdomen, lymph nodes, lungs, and liver. Ovarian carcinoma is the most common type of ovarian cancer. Comprising more than 95% of cases, there are five main subtypes of ovarian carcinoma, of which high-grade serous carcinoma, HGSC, is the most common. These ovarian tumors are believed to start in the cells covering the ovaries, though some may form at the fallopian tubes. Less common types of ovarian cancer include germ cell tumors and sex cord stromal tumors. A diagnosis of ovarian cancer is confirmed through a biopsy of tissue usually removed during surgery. Ovarian cancer statistics. In 2015, it was present in 1.2 million women and resulted in 161,100 deaths worldwide. Among women, it is the seventh most common cancer and the eighth most common cause of death from cancer. The typical age of diagnosis is 63. Death from ovarian cancer is more common in North America and Europe than in Africa and Asia. Ovarian cancer symptoms and signs. Early symptoms. Early signs and symptoms of ovarian cancer may be absent or subtle. In most cases, symptoms exist for several months before being recognized and diagnosed. Symptoms can be misdiagnosed as irritable bowel syndrome. The early stages of ovarian cancer tend to be painless. Symptoms can vary from any subtype. Ovarian borderline tumors, also known as low malignant potential, LMP, ovarian tumors, do not cause an increase in CA125 levels and are not identifiable with an ultrasound. The typical symptoms of an LMP tumor can include abdominal distension or pelvic pain. Particularly large masses tend to be benign or borderline. The most typical symptoms of ovarian cancer include bloating, abdominal or pelvic pain, or discomfort, back pain, irregular menstruation, or postmenopausal vaginal bleeding, pain or bleeding after or during sexual intercourse, loss of appetite, fatigue, diarrhea, indigestion, heartburn, constipation, nausea, feeling full, and possibly urinary symptoms, including frequent urination and urgent urination. Later symptoms. The growing mass may cause pain if ovarian torsion develops. Symptoms can be caused by a mass pressing on the other abdominal pelvic organs or from metastasis. If these symptoms start to occur more often or more severely than usual, especially after no significant history of such symptoms, ovarian cancer is considered. Metastasis may cause a Sister Mary Joseph nodule. Rarely, teratomas can cause growing teratoma syndrome or periodontal gliomatosis. Some experience menometrorrhagia and abnormal vaginal bleeding after menopause in most cases. Other common symptoms include hirsutism, abdominal pain, virilization, and an adnexal mass. Children. In adolescents or children with ovarian tumors, symptoms can include severe abdominal pain, irritation of the peritoneum, or bleeding. Symptoms of sex cord stromal tumors produce hormones that can affect the development of secondary sex characteristics. Sex cord stromal tumors in prepubertal children may be manifested by early puberty. Abdominal pain and distension also common. Adolescents with sex chordal stromal tumors may experience amenorrhea. As the cancer becomes more advanced, it can cause an accumulation of fluid in the abdomen. If the malignancy has not been diagnosed by the time it causes ascites, it is typically diagnosed shortly thereafter. Advanced cancers can also cause abdominal masses, lymph node masses, or pleural effusion. Ovarian cancer causes and risk factors. The risk of ovarian cancer increases in women who have ovulated more over their lifetime. This includes those who have never had children, those who begin ovulation at a younger age, and those who reach menopause at an older age. Other risk factors include hormone therapy after menopause, fertility medication, and obesity. Factors that decrease risk include hormonal birth control, tubal ligation, and breastfeeding. About 10% of cases are related to inherited genetic risk. Women with mutations in genes, BRCA1 or BRCA2, have about a 50% chance of developing the disease. BRCA mutations are associated with high-grade, serious, non-mucinous epithelial ovarian cancer. Family history also plays a role. In the United States, 5 of 100 women with a first-degree relative with ovarian cancer will eventually get ovarian cancer themselves. 7 of 100 women with 2 or more relatives with ovarian cancer will eventually get ovarian cancer. In general, 5 to 10% of ovarian cancer cases have a genetic cause. Environmental factors are also suspected. Industrialized nations, with the exception of Japan, have high rates of epithelial ovarian cancer, which may be due to diet in those countries. Race can also put you at a greater risk. Caucasians are at a 30 to 40% higher risk for ovarian cancer when compared to Black and Hispanic people, likely due to a socioeconomic factors. White women tend to have fewer children and different rates of gynecological surgeries that affect risk for ovarian cancer. Other factors include increased age up to the 70s, smoking, low levels of vitamin D in the blood, presence of inclusion ovarian cysts, and infection with human papillomavirus. Case control studies have shown that use of perineal talc does increase the risk of ovarian cancer. Sitting regularly for prolonged periods is associated with higher mortality from epithelial ovarian cancer. Ovarian cancer diagnosis. Diagnosis of ovarian cancer starts with a physical examination, including a pelvic examination, a blood test for CA-125, and sometimes other markers, and transvaginal ultrasound. Sometimes a rectovaginal examination is used to help plan a surgery. The diagnosis must be confirmed with surgery to inspect the abdominal cavity, take biopsies, tissue samples for microscopic analysis, and look for cancer cells in the abdominal fluid. This helps to determine if an ovarian mass is benign or malignant. Ovarian cancer's early stages 1 and 2 are difficult to diagnose because most symptoms are nonspecific and thus of little use in diagnosis. As a result, it is rarely diagnosed until it spreads and advances to later stages 3 and 4. Screening is not recommended in women who are at average risk, as evidence does not support a reduction in death and the high rate of false positive tests may lead to unneeded surgery, which is accompanied by its own risk. Ovarian cancer treatment. If caught and treated in an early stage, ovarian cancer is often curable. Treatment usually includes some combination of surgery, radiation therapy, and chemotherapy. Surgical treatment may be sufficient for well-differentiated malignant tumors and confined to the ovary. Addition of chemotherapy may be required for more aggressive tumors confined to the ovary. For patients with advanced disease, a combination of surgical reduction with a combination chemotherapy regimen is standard. Borderline tumors, even following spread outside of the ovary, are managed well with surgery, and chemotherapy is not seen as useful. Second look surgery and maintenance chemotherapy may not have been shown to provide benefit. Surgery. Surgery has been the standard of care for decades and may be necessary in obtaining a specimen for diagnosis. The surgery depends upon the extent of nearby invasion of other tissues by cancer when it is diagnosed. This extent of the cancer is described by assigning it a stage and presumed type and the grade of cancer. The gynecological surgeon may remove one unilateral oophorectomy or both ovaries, bilateral oophorectomy, the fallopian tubes, salpingectomy, uterus, hysterectomy, and the omentum, omentectomy, may also be removed. Typically, all of these organs are removed. Chemotherapy. Chemotherapy in ovarian cancer typically consists of platins, a group of platinum-based drugs combined with non-platins. Common therapies can include paclitaxel, cisplatin, topecatin, doxorubicin, epirubicin, and gemcitabine. Carboplatin is typically given in combination with either paclitaxel or docetaxel, and typical combination in carboplatin with paclitaxel. Carboplatin is superior to cisplatin in that it is less toxic and has fewer side effects, generally allowing for an improved quality of life in comparison, though both are similarly effective. Three-drug regimens have not been found to be more effective, and platinums alone or non-platins alone are less effective than platins and non-platins in combination. Radiation therapy. Dysgerminomas are most effectively treated with radiation, though this can cause infertility and is being phased out in favor of chemotherapy. Radiation therapy does not improve survival in people with well-differentiated tumors. In stage 1C and 2C cancers, radiation therapy is used after surgery if there is the possibility of residual disease in the pelvis but not the abdomen is cancer-free. Radiotherapy can also be used in palliative care of advanced cancers. A typical course of radiotherapy for ovarian cancer is 5 days a week for 3 to 4 weeks. Common side effects of radiotherapy include diarrhea, constipation, and frequent urination. Hormonal therapy. Despite the fact that 60% of ovarian tumors have estrogen receptors, ovarian cancer is only rarely responsive to hormonal treatments. A Cochrane review found a lack of evidence about the effects of tamoxifen in people with relapsed ovarian cancer. Estrogen alone does not have an effect on the cancer, and tamoxifen and letrozole are rarely effective. Some women with borderline malignancy, ovarian cancer, and stromal ovarian cancer may receive hormonal therapy. Immunotherapy. Immunotherapy is a topic of current research in ovarian cancer. In some cases, the antibody drug bevacizumab Though still a topic of active research, is used to treat advanced cancer along with chemotherapy. It has been approved for this use in European Union. Follow-up. Specific follow-up depends on, for example, the type and stage of ovarian cancer, the treatment, the presence of any symptoms. Usually, a checkup appointment is made about every 2 to 3 months initially, followed by twice per year for up to 5 years. Ovarian cancer survival. Ovarian cancer survival depends on the extent of the disease, the subtype of cancer present, and the other medical conditions. The tumor usually has a relatively poor prognosis. It is disproportionately deadly because it lacks any clear early detection or screening tests, meaning most cases are not diagnosed until they have reached advanced stages. The 5-year survival rate for all stages of ovarian cancer is 46%. The 1-year survival rate is 72%, and the 10-year survival rate is 35%. For cases where diagnosis is made early in the disease, when the cancer is still confined to the primary site, the 5-year survival rate is 92.7%. About 70% of women with advanced disease respond to initial treatment, most of whom obtain complete remission, but half of these women experience a reoccurrence 1 to 4 years after treatment. Brain metastasis is more common in stage 3 and 4 cancer, but can still occur in cancer stage 1 and 2. People with brain metastasis survive a median of 8.2 months, though surgery, chemotherapy, and whole brain radiation therapy can improve survival. Ovarian cancer prevention. People with strong genetic risk of ovarian cancer may consider the surgical removal of their ovaries as a preventive measure. This is often done after completion of childbearing years. This reduces the chances of developing both breast cancer by around 50% and ovarian cancer by about 96% in people at high risk. Women with BRCA gene mutations usually also have their fallopian tubes removed at the same time, salpingo oophorectomy, since they also have an increased risk of fallopian tube cancer. However, these statistics may overestimate the risk reduction because of how they have been studied. People with a significant family history for ovarian cancer are often referred to a genetic counselor to see if testing for BRCA mutations would be beneficial. The use of oral contraceptives, the absence of periods during the menstrual cycle, and tubal ligation reduce the risk. There may be an association of developing ovarian cancer and ovarian stimulation during infertility treatments. Endometriosis has been linked to ovarian cancers. Human papillomavirus virus infection, smoking, and talk have not been identified as increasing the risk for developing ovarian cancer. Thank you for watching to the end. Please like the video and subscribe to the channel to signal YouTube to share the video with more viewers. If you are an ovarian cancer survivor or professional, kindly share your experience with our viewers.